I don't. Hello, Marietjie. Are you here? Hello, Dr. Cilliers.
Hi, sorry, I just had my headset off. How's it going?
Hello. Can you hear me?
I can hear you.
Fine, thank you. So I hope that everything is all right at your end. Let's try. Okay, that's it.
There we go.
Okay, so we are very honored to receive you again in this webinar series. I hope that we'll learn a lot from you, as we have done already last time with the first of your webinar, which was on the diagnosis and management of leaks and conjunctiva. And today we will have another talk on diagnosis and management of cornea and traumatic events. So shall we start in a few moments, because it's around 5. It's 2 minutes to 5. Meanwhile, we can ask, we can share some thoughts. How is optometry in South Africa at the moment?
It's going well, thank you. If it wasn't for all the power problems, so sorry guys for canceling the last time. We've had so much problems with power, and yeah, so we've made other plans now, but the power is all right tonight, but I've got backup generators and stuff just in case. But optometry is fantastic as always. We love what we do, and that makes life a lot more enjoyable.
Yeah, we are. Well, you are actually South Africa is the leader in optometry in Africa. We used to have this kind of advance in comparison with other countries such as Algeria. Even if in Algeria we had the opportunity to get a university program in 1972, and we had some optometrists around 1976, 77, and then but we are. It's not the same situation. You are mostly South Africa is in a university way, very close to Australia and to the States. So you have benefited from some kind of help from universities from around places such as Australia and South Africa and America and North America. Mm-hmm. So my friend René Combe is already here. So Dr.
Hi, hello, bonjour.
Dr. René Combe is a doctor on optometry from Boston University, from New England College of Optometry, and he is actually administrator with in the FCU group. So he has given us such a wonderful talks already on myopia, his main field myopia, and also comportamental or behavioral optometry. So I just dropped some lines which I have written, trying to introduce you in French already, because maybe all people here are from North Africa and from South Europe. So c'est un résumé tout d'abord, bonsoir. On remercie Dr. Marietjie Cilliers pour nous honorer une deuxième fois avec une conférence sur le segment antérieur. Et cette fois-ci, après nous avoir introduit il y a quelques mois de cela sur la pathologie et la gestion la pathologie et la gestion de tout ce qui est aspect lié aux paupières et à la conjonctive. Aujourd'hui, elle va nous introduire à la pathologie et à sa gestion concernant la cornée, aux pathologies et la gestion concernant la cornée et les éventuels traumatismes. Donc, Dr Marietjie Cilliers a obtenu son baccalauréat en optométrie, c'est-à-dire sa première graduation en optométrie en 2008 à l'université de Durban, Westville, en Afrique du Sud. Fin 2012, elle a obtenu son diplôme d'études supérieures en diagnostic et lentilles de contact avancées via le New England College of Optometry, États-Unis. En octobre 2017, elle a obtenu un autre certificat d'études supérieures en thérapeutique oculaire via la State University of New York, SUNY, aux États-Unis. Elle est maintenant autorisée à utiliser et prescrire des médicaments thérapeutiques oculaires au besoin. Elle est également la fondatrice principale de GuruMed, une plateforme d'apprentissage internationale unique et passionnante qui vous propose une formation pratique en soins oculaires. Donc, si vous êtes intéressé, à la fin, elle va nous donner le lien si vous voulez vous inscrire à cette plateforme pour apprendre plus et mieux tous les aspects liés à la pathologie, à la gestion des aspects pathologiques. Elle est l'auteur d'un guide pratique de Vision Stress sur les conditions du segment antérieur qui est désormais disponible au format Kindle sur Amazon. En 2020, elle a obtenu sa certification clinique auprès de l'association Start Griffin Dyslexia et est maintenant habilitée à faire le diagnostic de la dyslexie et son suivi et son traitement. Elle est devenue membre de l'American Academy of Optometry en novembre dernier, en novembre 2011. Ses intérêts particuliers sont les pathologies, les maladies pathologiques de la surface oculaire et la gestion de la sécheresse oculaire. À côté de cela, elle est d'abord, une chose qui est certaine, d'après ce que j'ai vu comme publication, c'est une fervente religieuse, il faut le dire. Donc, elle est très croyante. Elle a une pratique solide qui est axée sur un excellent service amical. Au cours des dernières années, elle a continué à pousser professionnellement et s'efforcer d'accroître ses connaissances. Donc, sans plus tarder, je vous présente donc notre oratrice de cette fin d'après-midi, Dr Cilliers Marietjie. So you can carry on if you would like.
Thank you so much. You know, that is a mouthful in English, never mind in French. It's like, that's quite a mouthful. So no, thanks for having me.
Let me just give, I will give you the possibility to share.
Yes, please.
Okay, good. That's it. Okay, it's all right. Has been done.
There we go. There we go. Right. Good. So yeah, from my side, thanks again for having me, and my big apologies for having to cancel the last time. Yeah, in Africa, things happen. So I think we're getting used to it by now. But yeah, I'm very privileged to be able to have this discussion with you guys tonight. So we've got quite a big section to get through. When we talk about ocular surface disease, you know, cornea is probably the biggest one that we deal with. So it's important that we actually look at this thoroughly and make sure that, you know, we have a good idea of what it is that we're dealing with. So, sorry, I just had the trauma one. Let's get to the right one. We're going to start off with the corneal disease. So just, yeah, so as Gwati was saying, just to introduce myself a little bit and just to explain you guys what I'm about. So I'm a specialized optometrist from South Africa, and the book, The Practical Guide to Anterior Segment Conditions, is pretty much the place where all of this started off for me, you know, and kind of opened the doors for the webinars and the conversations. So I would really encourage all of you to go and have a look. You can get it on Kindle or on Amazon. It's really a great desktop resource, and it covers drugs for the Southern Hemisphere African market, as well as it has the American drug list in there as well. So it all depends on what you have available in your country, but you should be able to have something in there that will suit your needs. And then GuruMed has been something that kind of developed just before the COVID lockdown period, and luckily for us, it was ready to go when everyone was in lockdown. So there's a couple of courses, of which this anterior segment section that I've been sharing with you guys is a course on the system, where we go through this in detail and what drugs we use and why, and a couple of more discussions on these. So check it out, mygurumed.com. Okay. During this whole conversation, and I just wanted to share this slide because in my book and in these conversations, I use a lot of icons. I like pictures. I think in pictures, it makes my life easier. So these are the icons that I use. They're quite self-explanatory, but it's kind of the symptomatic icon to show you what the patient would be feeling and kind of experiencing in these specific conditions. Okay. So let's not waste any more time. Let's get into it. We're going to start with the corneal section, and every heading is alphabetic. So we're going to go from A to Z. So you guys can look at most of the corneal diseases that you'll find in primary practice. These are the ones that are therapeutically managed, and there's a couple of other ones that I've included, and it's not all keratitises. So for instance, something like keratoconus is not included because it's non-infectious, non-therapeutic. You know, it's something that is not really managed therapeutically. So these are focused on therapeutic management. What do you do in terms of drug management for these conditions? Okay. So starting off with acanthamoeba. Acanthamoeba is one of those ones that you really wish you never see. Luckily for me, I have not. And it's one of those things that you kind of notice a little bit later on. So acanthamoeba keratitis is a sight-threatening condition where you have this acanthamoeba infection of the cornea, but it kind of, the idea with this, it kind of initially looks like a normal bacterial ulcer. And in about 5 to 7 days, it starts making this defined white ring with a hazy zone in the middle, like that picture shows, you know. And the problem with acanthamoeba, it is incredibly vicious. It's a very vicious organism, and it'll completely devastate and absorb the ocular tissues as it actually spreads through ocular tissue. So this is an absolute emergency. This patient is very likely to lose their sight, if not their eye, completely. So if you see this in practice, these are one of those things that you manage as a first-line care, but they always have to be referred out, you know, to emergency unit. Okay, but the patient will normally present very similarly to a bacterial ulcer. So they'll have the pain, they'll have the photophobia, the blurry vision, and a red eye, and you'll have a possible dendrite, epithelial dendrite, and this subepithelial infiltrate. So this ring infiltrate is the really classic sign of an acanthamoeba keratitis. Okay. Late onset, when it has progressed, you'll have the hyperemia, and you'll probably have an anterior segment reaction as well. And that's why I say it's very similar to bacterial, except it doesn't have the discharge. Right. Now, remember, I said that this is a referral case. So the management that you are going to do is literally just to get the patient on some form of care so that they can get to an emergency unit ASAP. Now, what the suggested management here is a broad spectrum antimicrobial drop, where propamidine is probably the one that's the most commonly used, you know, and then neomycin. Neomycin is the go-to antibiotic for acanthamoeba. The problem with neomycin is you don't always get it. So like in Africa, neomycin is not available in isolation. But in the US it is. And that is something that you'll probably want to do, and you'll give it at high dose, like every 10 to 15 minutes, but you'll still refer the patient off to go to emergency care to be able to be put on an IV drip and have antibiotics administered through drip to make sure that that acanthamoeba infection does not spread much further than that. Okay. The oral NSAIDs is there for pain relief, just to make sure that the patient can cope with the pain. Now, if you were in my discussion the last time around NSAIDs, and I just think I must say this before we carry on because this will come up a lot throughout this discussion. NSAIDs is non-steroidal anti-inflammatory drugs, and you want to preferably use oral NSAIDs to topical NSAIDs. So topical NSAIDs have the habit of creating corneal melts and things like that. So it's always more effective and long lasting in an oral form. Keep in mind that oral NSAIDs are contraindicated in stomach problems. So things like stomach ulcers, gastric problems. So you want to weigh up the pros and cons when you're giving the oral NSAIDs, you know, with the patient's general health. So if they have stomach problems, a topical might be a better option, but this is for pain relief only. So there are other options to give a patient if an NSAID is not indicated. Right. Now, another thing with these patients, steroids, and you'll see there, steroids are sometimes given but only once the infection has resolved or the bacteria has completely been eliminated, which is kind of a bit of a problem because when does that actually happen? Okay, so in these cases, I really would not suggest you managing them actively. You want to refer them out. Here I did say the follow-up, so you'll follow them up every day, you know, to make sure that there's improvement, and then every month for 3 months. So this will be done by the ocular specialist to ensure that this acanthamoeba infection doesn't actually continue to spread. All right, so that takes us into bacterial ulcers, a much more common thing you will see in practice. And bacterial ulcers are actually not that easy to get. You'll find them most often in elderly patients with a comorbidity or a co-leading other infection, and very often something like blepharitis. So you'll sit with an elderly patient with chronic blepharitis, and the fact that the bacteria is just there, they just this opportunistic kind of little bug. So the moment the patient gets a corneal abrasion or something like that, this thing will escalate and turn into a bacterial ulcer. The classic signs with bacterial ulcers are these really gunky, thick discharge, very often into a hypopion. So remember, it's pus in the anterior chamber. And then obviously this clouded cornea with a possible area of clearing in the middle. So what you guys will see, and this one was actually quite severe. Let me just get my pen because I like drawing on things. So as you guys will see, is there's a little area of clearness there, okay? The problem here is that this ulcer was already so far along that it was actually causing a huge ectasia on the cornea. So it was thinning that cornea out so badly. And it was actually perforated. So you can't see it very well there, but the iris was already plugging the back of the corneal surface because the cornea had already perforated from that corneal ulcer. The ironic thing with this patient is that she actually had no pain. She came in complaining of vision and discharge, but she had zero pain, which to me was just like mind-blowing. I mean, how can you not have pain with something like this? And that's actually very important to look out for that. Just because there's no pain doesn't mean that the patient doesn't have something this severe. They might just not have, or they might have corneal desensitization because of whatever other reason, and that really results in a very, very poor result. So she perforated and unfortunately lost that eye completely because the fact that her lack of pain actually drove her to come to me too late, okay? So, and again, remember, this is associated with other conditions, very often blepharitis, very often elderly patients with a low immune system, okay? So the signs is this epithelial defect. You'll have staining when you put fluorescein on that eye. And the classic thing here with a bacterial ulcer versus a kind of an abrasion is the fact that you have a leading edge. Now, I'm going to try and explain that. So when you stain, you'll have a green fluorescent circle, but there'll be a hazy boundary to it that doesn't stain, right? And that's the leading edge of the actual infection. So as the bacteria spreads, it causes this haze, and then the epithelial break is slightly smaller than the haze around that break, okay? Where with a normal abrasion, you don't have that hazy circle around the outside of the abrasion or the epithelial defect itself. Very often here, you also have the uveitis and the anterior segment reaction with the hypopion, and obviously the corneal or conjunctival hyperemia. This eye, you can see even the eyelashes, there's discharge and gunk all over that eye. Right. Here, what to do, a topical cycloplegic. So that's for the anterior segment reaction to help with the uveitis, and a big broad spectrum antibiotic, and preferably with something with Pseudomonas cover. So at the moment, we all love the fluoxetins, the newer generation, fluoroquinolone drops. So at the moment, we just got becifloxacin. So I don't know in the rest of Africa if that's available yet, but becifloxacin is a specific ocular fluoroquinolone. It's not made in an oral form, which means it's got less resistance. and obviously more effective because of that, you know. So the big problem we have with antibiotics, we know, is that patients have resistance because they take so much of it orally, and fluoroquinolones are also now used quite commonly in an oral antibiotic. So you want to go to the becifloxacin, its trade name is Besavance. This is a really good option, you know, for something like this. And then obviously at nighttime, I always like to put an ointment into that eye, so an ointment antibiotic, just to make sure that there's cover during the night while they're sleeping. Again, you'll see the oral NSAIDs for pain relief. Again, keep in mind on the gastric system and whether that is contraindicated. You'll follow this patient up daily, same with acanthamoeba. So any form of infective keratitis, you want to really keep a finger on it, because what should happen is day one, you should have maybe nothing, maybe slight improvements. You're not expecting it to get better, but you're expecting it not to get worse. Okay, you measure your epithelial defect, you measure your hazy border, your leading edge, so you can make sure that that defect is not actually getting larger, okay, because that would mean that your treatment is not working. Okay, and you want to be able to refer that patient out for IV management as soon as possible, because perforation with bacterial ulcers can occur very, very, very quickly. Okay, so day one, day two, and you want to make sure at least by day 7, you should have, depending on how big the defect is, but preferably you should have resolution by day 7. And it should have been improved by 50% at least by day 3. Okay, and if it doesn't, you want to send them out for IV treatment. Right, then the next thing is contact lens complications. Now, I just want to stop there and say a lot of corneal issues and a lot of corneal keratitises that you will see is actually contact lens related. Okay, many patients coming in will have a form of keratitis in association with contact lens wear. I actually had an interesting one today, which I might as well share with you guys. It was a youngster in high school. She came in complaining of a very painful eye. Nothing happened, nothing went into her eye. She just said the eye was sore. And the moment I looked at her eye under the slit lamp, I just realized something was up, you know. So I asked, do you wear contact lenses? And she goes, yeah, occasionally. And my next question was, okay, do you sleep with your contact lenses? She goes, yeah, occasionally. I'm like, okay, did you sleep with them last night? And she goes, yes, you know. And then the next question was, okay, but how old are these contact lenses? And her response was, well, probably like 6 months, you know. So she's been wearing a single monthly lens now for 6 months, nonstop, without taking them out, sleeping with them. And she's like 16 years old. Okay. Needless to say, she's not a patient of mine. And yeah, we had a very, very strong conversation. But this was not something that was forthcoming when the patient actually walked into my office, you know. So it's always good to ask this question. You know, if a patient comes in with an acanthamoeba, with a bacterial ulcer, with any form of corneal staining, with a corneal abrasion, you need to know if there's any form of contact lens involved, because that changes the ball game. You're sitting with waterborne organisms, Pseudomonas is another one, and you want to make sure that you treat it effectively, because if you don't treat it as a contact lens issue, you might give the wrong treatment. Right. So back to the question at hand, we're looking at contact lens related complications. And most contact lens complications has got to do with maybe a bit of corneal staining, maybe an abrasion, maybe some dryness. You could have infiltrates, you could have obviously the hyperemia, and then if it goes more severe, you can go into ulcerations and then infections in that case. Again, you've got the foreign body sensation. That's probably the most common complication with contact lenses, the red eye, the blurriness, the burning. And again, remember to ask them, do they sleep with them? You know, because they won't want to tell you, because they know that they shouldn't have. And it's very often something like Claire or something like a bacterial infection, because they are overusing their contact lenses. Okay, so the management for contact lens complications obviously is the discontinuation. I always suggest that patients lens hygiene, material fitting, and things like that. So this is where the conversation is important. How is the patient managing their lenses? What are they using to clean their lenses? How often do they clean them? How often do they take them out? Have those conversations, because patients don't do what they are told to do. Right, then how often do you follow them up? 24 hours in, again, making sure that there's no infection, making sure that it doesn't get worse, and then 1 week to ensure resolution. Okay, then we go into DELIN. Now, DELIN is something that a lot of practitioners miss and kind of only class it in the area of pinguiculitis. You know, and they say, okay, it's this pinguiculum, the inflamed pinguiculum. They kind of miss this little area in between. So what happens with DELIN, there's a little indentation or a bump. No, the bump is out. Now, it's kind of a dip between the pinguiculum and the cornea before the pinguiculum and the cornea comes together. So what literally happens is the two areas where they're supposed to come together actually makes a little indent back into the eye. And that area there, the epithelium there, becomes incredibly dry. Okay, and this dry zone causes, I always like to refer to it like an eczema spot. Anyone who's ever had eczema will understand what I mean, where the skin just kind of cracks up and just dries out in that specific area. And it becomes incredibly painful because it's on the limbal zone. Very sensitive, very red, very irritated, you know. So what I've always found with these patients is they come in complaining severely about this discomfort and this pain. And then you look at the eye and you don't understand why they're complaining so much, because it doesn't actually look that bad. You know, they've got the pterygium and it's there, but it's not really that bad. But then when you stain it, you can see that it actually creates this staining in that little indent, you know. If it continues and it gets really bad, it could create a marginal ectasia. You know, the cornea there can actually really start thinning down, and it can cause marginal ulcerations as well. Okay, so this is really something that we need to look for in our pinguiculum pterygium patients. Right. Now, the management here, so here it says if there's no epithelial defect, you can just lubricate and put some ointment at night. Now, be careful if we talk about no defect, it's actually kind of very difficult with this, because the moment you put fluorescein in, it's going to go and pool in that little hole there, you know. So it's going to look to you like it is fluorescing, but it's actually just the tears pooling there. So make sure you take the lid and you just kind of rub it over that area to get rid of the excess tears there, to see if it's staining or if it's just pooling. Okay, so be careful with that. Obviously, if there's an epithelial defect, you just want to cover it with some antibiotic so that it doesn't actually get worse. Now, in this case, you'll see I talk about an antibiotic ointment. I don't like ointments in general because patients really complain about the gunky, you know, kind of sticky feeling that ointments give. But because there's a very big dryness component and friction component to this problem, the ointment works really well because the viscosity of the ointment also helps with the dryness factor, you know. And so you don't have to do a lubricant and antibiotic at the same time. You can just do the antibiotic in an ointment form and it should cover the problem, okay? The thing with this is you want to educate the patient why this is happening, and that a lubricant or a chronic lubricant is probably a good idea to try and avoid this from recurring all of the time. The follow-up here is again 1 week after you've put them on treatment and making sure they understand the chronicity of the issue. Okay, then we go into epidemic keratoconjunctivitis. So in the last discussion we had previously, we were talking about conjunctivitis and we talked about viral conjunctivitis, adenovirus conjunctivitis. Now, epidemic is what happens if adenovirus conjunctivitis just like completely goes on steroids and like takes over the whole eye system. So this is an adenovirus infection that creates this and it's quite unique, you know, in its presentation, because you have this red, very red, teary eye and itching. It's generally very, very itching. in its acute phase, you might not even have the pseudomembrane or anything like that. So you might just have the follicles and the red itchy eye, but it progresses very quickly, you know, and what happens after that, it has the pseudomembrane. So a pseudomembrane is like a film or like a skin that grows in the tarsal conjunctiva that you can actually move, you know, it actually kind of moves around, okay? And then obviously you have this follicular response, hyperemia, and then the subepithelial infiltrates will happen a little bit later on. Now, I've always found it difficult with these cases with the follicles and the papillae. It's very difficult to differentiate because sometimes they have both, because it's also an inflammatory response to the virus. And that's why you have subepithelial infiltrates, because there's an inflammatory response to this viral infection. So the viral infection creates the follicles and the pseudomembranes, but the body's response to that virus creates the inflammatory response, which is the papillae and the redness, you know, and the SEIs that goes with that. Okay, so keep in mind that you've got both an infective and an inflammatory component, which makes the treatment a little bit more tricky, and I'll tell you why now. Okay, so the main thing with this, and we actually had a conversation with a colleague in the US, when they have a case like this, you have to go and sterilize everything. Okay, so we know viral conjunctivitis, the normal pink eye, is contagious. This one is incredibly contagious. So you will give it to every next patient that walks into your door. So you have to sterilize everything from your chair all the way down to your table, and don't forget your pen. That's one of the biggest problems with managing ocular infections is we forget our pen. We're using this to write, we're managing the patient, you know, and you go back and you write something down, but you forgot to actually sterilize your pen. So remember to sterilize your whole table and your pen and everything to make sure that you don't transfer this onto the next patient. So just again, in terms of symptoms, the classic symptom here is the teariness and the itching, you know, so the eye is really itchy like it does, you know, with the pink eye. So what do we do in terms of management here? Okay, we need to reduce the viral load to the eye. We need to make we need to have less virus in the eye to be able to resolve it quicker, okay? Now the pseudomembranes is like an accumulation of viral tissue in the eyelid, okay? So one of the most important things to do with these patients is remove the pseudomembranes so that the eye can actually recover. So you'll put a drop of anesthetic, and then you will literally just pull away those pseudomembranes. It's not a difficult thing to do. You can do it with a tweezer. It doesn't have to be cut. They literally just pull away like you normally, like you pull a Velcro apart, you know, it just pulls off. There will be some bleeding in that, so don't have a fright if that happens, because sometimes the pseudomembrane embeds itself slightly in the superficial conjunctiva. So there might be some bleeding, and it's really nothing to worry about. It's more important to remove those pseudomembranes, and then you can actually manage with whatever antimicrobial. In this case, research always says that povidone iodine bath is an incredibly good way of getting rid of that virus. So we all know that adenovirus has got no treatment. Okay, so adenovirus cannot be treated. It kind of has to go its course and die out by itself. But povidone iodine has shown in the case of an epidemic keratitis to really kill the excess adenovirus load that's there and make the eye non-contagious from that point forward. So what you'll do is you'll have an irrigation system, clamp the eye open, and literally pour povidone into that eye. Keep in mind, povidone iodine is incredibly toxic. So you will sit with the keratitis as SBK and you'll burn the epithelial of the front surface of that eye, but it's par for the course, you know, so it's a better option to be able to get rid of the viral infection. You can fix the SBK after the fact. Right, that's what the preservative-free artificial tears is for. And then once the viral load is dispersed off, you can then put the patient onto a corticosteroid, which will sort out the inflammatory side, which is the subepithelial infiltrates and the redness. But make sure that you are 100% sure that the virus is dispersed. Because if you're going to give a patient a steroid on top of an active virus, you are going to just absolutely escalate it. So corticosteroids are contraindicated in viral infections, well, any infection for that matter, but it's in this case the only way to actually treat subepithelial infiltrates. Now, how do we follow this up? You want to follow up within a week. If you have done a povidone iodine bath in the office, 1 week is sufficient. If you haven't, and you've put the patient on an antimicrobial, something like propamidine, then you're going to follow them up daily to make sure that it actually does improve, okay? And you will keep removing any further pseudomembranes that might pop up over that period of time, right? And then you want to see them about 2 to 3 weeks later. That's when the subepithelial infiltrates will start popping through, and they might actually get very large, and if they're very large, they can really affect a patient's visual, visual axis, and you will then have to manage that with corticosteroids. All right, now we're heading into filamentary keratitis. Now, filamentary keratitis is directly associated with dry eye, and most oftenly there is some form of systemic problem. This is very common with patients like in Sjogren's syndrome, where there's some form of problem with the aqueous side of the tear film. So how filamentary keratitis works is that the aqueous becomes very, very low, and the mucus and the oil, the mucus and the oil actually comes together, and they form these little mucin balls, between the meibum and the mucus. That's what the word I was looking for. Between the meibum and the mucus, they come together, they form these little mucin balls. And because there's no lubrication on the front surface, there's no aqueous layer, the mucin balls just kind of get stuck to the epithelial surface, And it's almost like this little dumbbell. It's got this little tail and this little thick end on the front, and every time the patient blinks, that mucin ball just kind of is pulled up and pulled down and pulled up and pulled down, and it pulls on the corneal epithelium every time. This is a highly uncomfortable condition. It's very sight worrying because if the filaments are in the visual axis, it's really, really sight disturbing. But the pain and the discomfort is probably the most common complaint with these patients, okay? So you want to make sure and you want to look at the systemic side of a patient like this, because there's definitely a systemic component that's creating this issue. Something else you'll obviously see in this case is you'll have the hyperemia. The hyperemia is there because the eye is uncomfortable and inflamed due to the dryness and the kind of friction between the eyelids and the filaments and the ocular surface. And then you'll have, very often you'll have some form of corneal staining, some SPK, again related to the dryness, not so much the filaments itself, but that ocular surface is terribly, terribly dry. And in this photo, you can actually see that this bottom lid is kind of drooping away from the eye slightly, okay? And you can actually see that there's staining on the lid margin, and you don't really see a very large tear lake either on the top, or there's nothing at the bottom, okay? So there's no aqueous production in this eye. So how do we manage this? So extensive lubrication, and we're not going to discuss dry eye and dry eye disease management in these talks today, but that is a whole discussion by itself. Dry eye really can have an incredibly big impact on a patient's quality of life, and there's so many different ways of managing this. So we're not going to go into that in great detail. This management says lubrication is the way to go. In terms of aqueous deficient dry eye, punctal plugs is probably also a very good option to try and make sure there's a little bit of aqueous remaining there. But the problem with filamentary keratitis is the inflammatory component, and that creates the problem even with plugs. So like this says, is you have to manage the underlying condition, the systemic issue that's available, that's present in this case. Now, the acute management is the debridement of those filaments. So the big problem is the fact that the eyelid is kind of pulling these filaments up and down, and that's what creates the pain. So you debride the cornea, get rid of the filaments, which creates a corneal abrasion. You'll manage this case like a corneal abrasion with an antibiotic or a bandage contact lens if it's extensive enough, and continue with the lubrication. So once you have the cornea clean, you have to keep the lubricant going, but then the chances of the filaments recurring quickly is much less because now you've already cleaned them up and they can stop getting attached to each other. Okay. You want to do a corticosteroid for the inflammatory portion, getting rid of the pain and the inflammation all over the eye. And then autologous serum. Autologous serum is actually a great solution. And I don't know how many of you guys have actually used autologous serum, but it is fantastic. The problem with autologous serum is it's quite pricey if you buy it from a supplier, but it is really, really good because it has all the good growth factors from blood serum, and it really keeps the eye moist and healthy, much better so than with any other form of lubricant. Then in severe cases, if it's necessary, you can go to amniotic membranes or scleral lenses to actually protect that corneal surface from the dryness problems. Okay. Follow this case up. So if I would say if you were debriding, you want to follow it up at least within 24 hours to make sure that the cornea is healed up again. And then you can do a weekly visit until 4 weeks. And like I say, the bandage contact lens is a good idea if you're going to debride the cornea as well. Good. This takes us into fungal. Now, this is one of the other ones I am very happy that I've never seen myself before. Between this and acanthamoeba, I think you don't want to ever have patients like this in your chair because these are really, really difficult to manage and very difficult to save these eyes. Okay, so the classic, shall I say, case history behind a fungal keratitis is a patient would come in and I'd say this very painful eye. So this is also incredibly painful condition, red, photophobic, and it's got the same discharge profile as a bacterial ulcer. And when you ask them a little bit more, they would actually tell you that there was a history of some episode. So they had something in the eye or something scratched their eye or something went into their eye, maybe in a previous episode about 2 or 3 weeks prior to this pain event. Okay. This happens because of some form of abrasion or some form of laceration caused by a vegetable matter. Textbooks always talk about vegetable matter, anything that's from a tree or that can carry some form of fungal spore. So even fingernails works, even animal nails, something like that. And normally at about week 2 after the resolution of that initial abrasion event, this starts to flare up. Okay, and when you look at the patient under the slit lamp, the first thing you'll have this kind of infiltrate and it doesn't stain. So this front surface is, or the epithelium is intact, but you have this kind of cloud or puffy cotton candy look on the inside of the stroma of the cornea. It does sometimes happen that you have an epithelial defect. It's not uncommon, but it's very more common that the epithelial might be intact. Okay, so you've got this kind of cloudy looking infiltrate with cloudy borders, and it doesn't have dendrites, but it's just this kind of fluffy look to it. You have the redness, and then you have the same reaction, the same anterior chamber reaction as you have with a bacterial. You have this hypopyon, you have the uveitis, and you have this incredibly painful eye. So how do we manage this? Topical antifungals, so netamycin and amphotericin is, or netamycin is the one. Normally you can get netamycin over the counter. Unfortunately in South Africa, we do not have netamycin in a already made drop. I know in the US you do, it's called netacin or something like that. And then amphotericin is a compounded antifungal drop that you can order. So at a compounding pharmacy, you can actually say that's what you want. And these eyes need to get high doses of drops for long periods of time. Again, it's very similar to acanthamoeba in the sense that you want to just get this patient on some form of management and then refer them to emergency care, because this can spread very quickly and it is sight-threatening. The patient will lose their eye or their cornea, if not their whole eye, if this is not treated quickly. The cycloplegic again is there for the anterior chamber reaction. Oral antifungals are very important because, like I say, this spreads. And what they usually do is they debride the cornea to try and reduce the fungal load. So remember I said the fungus grows in the stromal system. So it actually goes in underneath into the stroma of the corneal tissue. And so trying to remove some of that fungal, parasites or fungal, particles, that's maybe the word. They normally go and they debride the epithelium and they try and get rid of the fungal load so that it actually can heal up a little bit quicker. Yeah. And again, like it says there, it helps to facilitate the penetration of the medication itself. Okay. Two things I might mention here is that, again, with this infective systems, topical steroids are contraindicated. And oral antifungals has got quite some contraindications systemically. So oral antifungals are contraindicated in patients with renal disease, and it can cause incredible symptoms, fatigue, depression, and chest pains, heartbeats, things like that. So this is something that needs to be closely monitored, preferably in a hospital setting where all the other side effects from the medicine can also be managed effectively. Okay, this patient is then also followed up on a daily basis. Improvement is slow, okay, but like I say here, the stabilization or the decrease, how do I say this? The not getting worse of this condition is a good sign, okay? Same with bacterial ulcers, same with acanthamoeba. The fact that it's not getting worse is a good sign, okay? It means that it's being kept under control, right? The problem is it takes very long to completely resolve this problem, and very often these patients and acanthamoeba patients result in corneal degradation, and they end up having to have corneal transplant. Right, sorry, just give me a moment. I'm not used to this anymore. We haven't done this for a while. All right, so this takes us into the herpes infections. And herpes are the manageable viral organisms. So herpes, there's an antiviral for herpes itself. And there's two types of herpes infections, herpes simplex and herpes zoster. Herpes simplex is generally the more common one, and it's the same virus as the one that gives fever blisters. So just as a bit of background for those that don't know, the herpes virus is dormant in one's system. You pick it up either through having varicella zoster infection, so the normal chickenpox infection, and that then takes that virus and it goes and it puts it dormant in one of the ganglion cell complexes somewhere in the body. Okay, very often patients have recurring fever blisters on the lips, and then it can happen that that herpes infection can travel along that nerve, especially the trigeminal nerve, the fifth nerve, because it all comes into the same ganglion in the root ganglion of the trigeminal nerve before it branches into its 5 branches throughout the face. So it is not uncommon for a patient that has had fever blisters on the mouth to also have a herpes simplex infection as well. The main thing here is it's very much immunocompromised or immune dependent. So it's when the immune system drops down and it's not able to keep the herpes organism under control, then it'll flare up. Okay, and I myself used to, I don't anymore for some reason, but I used to get fever blisters on my lips, and I'd always know wintertime, and when my immune system is broken down, or maybe have a bit of a flu, then I'll get a fever. So the moment your immune system gets a little bit suppressed, this thing will pop out. Okay. Now with herpes simplex, the classic sign of herpes simplex, the patient will obviously complain of the pain. There's wateriness. Now the difference between this and an adenovirus is the lack of itching. Adenovirus itches like an allergic conjunctivitis, but herpes does not. It's painful and it's got this teariness as well. Right, so you're expecting to see this dendrite on the corneal surface, and it's a true dendrite, which means that it stains. If you put fluorescein on it, you'll actually see it staining. Now, just as a little bit of a pull is I've had many herpes simplex infections that get to me a little bit early. So it still looks like maybe a small corneal abrasion or a small corneal laceration, just like a little line on the cornea, but there's nothing really else there. It hasn't started running into the dendrites yet. Okay. And then the moment you put them on an antibiotic, because now you're thinking, okay, it's an abrasion. If you see them the next day for their follow-up, it started running into the dendrite. So something worth asking these patients when they come in is, have they experienced any tingling or any kind of like a pins and needles effect in that area, on the side of the face, in the eye? Because it normally gives that little like a pins and needle effect because it's running on the nerve. You can actually feel it on the nerve endings, like a sharpish pain, stabbing pain, even in the eye itself, okay? And that's a good way of determining whether this could possibly be a herpes infection, okay? So again, the dendrite is a true dendrite, it stains, and you might actually sit with an anterior chamber reaction. So how are we managing this? This is topical antiviral drops in the day and then at night as well, if possible. And then oral antiviral therapy. Now, in the research, and this is this has become a bit controversial because research is saying is that if you give this patient an oral antiviral only, it should be sufficient and you wouldn't need the topical antiviral. I've done both. I can honestly tell you that I do think it resolves a little bit quicker when it has the topical antiviral as well, and not just the oral antiviral. But the oral is important to make sure that the actual nerve, that there's no neuralgia on the nerve itself, and that you can resolve this a bit quicker and make sure that it doesn't have a recurrence, because that's the problem with herpes simplex, is having this recurrence can actually damage the nerve itself, okay? Regarding topical antivirals, in some countries, the acyclovir is still available. We had it available till probably about 5 or 6 years ago, which at that stage it was taken off the market. That's still probably the best antiviral. It's fairly soft on ocular surface, and now it's not available. So now we've got Zovirax, the acyclovir option, or the trifluorimidine, which is the more common one that's available. And trifluorimidine is incredibly toxic to the ocular surface. So it creates extensive SPK, severe dryness, and it has its own complications. And especially with these patients, you have to dose very high. You normally dose like your topical antiviral 5 to 9 times a day to try and make sure that you get rid of this infection. So there's quite a bit of ocular surface, I'm going to say damage, but it's not damage, it's ocular surface influence, which you then also have to manage afterwards. Okay, again, this is kind of a, you've got to weigh up the pros and cons. You want to treat this, so it's very important to get rid of the virus. You can always treat the SPK after the fact. Right. Now, topical cycloplegics is also important because these patients will present with a uveitis most of the time, and the cycloplegics are there for pain management. Again, with these, follow them up from 2 to 7 days. I'm personally quite diligent with these things. I like to see my patients every day until I see that it's actually resolving, so I normally see them every day, at least until I have resolution, but that might be a bit too much. It's not always necessary. So day 1 and then maybe day 5 again should be quite sufficient. And then the most important thing with a lot of these herpes issues is making sure that there's no stromal disease and no recurrence after a period of time, okay? And then after 2 weeks, the topical steroid might be indicated to reduce the inflammation caused so that there's no clouding and scarring of that cornea. All right, then we go to herpes zoster. So herpes zoster is the classic face blister that runs down onto the nose, which is Hutchinson's sign, and which then you will know that there will be ocular involvement as well. I have personally seen more zoster infections just around the orbital area. than in the eye itself. So it makes these blisters on the eyelids, even to the extent that it goes onto the conjunctiva and the scleral tissue, but it actually leaves the cornea untouched. So that's been more my experience, and it's been more common, but it does happen that it actually also creates a corneal infection, the keratitis side of it, which creates a pseudomembrane. Now, the difference between this and herpes simplex, the pseudomembrane is the pseudodendrite. The pseudodendrite does not stain. So it looks the same under white light as with herpes simplex, but when you stain with fluorescein, your dendrite does not stain. Okay, so that's the main difference between the two, but you will see it because with herpes zoster, you have the external blister and probably running down to the nose. And again, here you can have uveitis. The problem with herpes zoster is you've got to keep in mind that this might be a deeper, more systemic condition. So you want to rule out other inflammatory issues like scleritis, retinitis, choroiditis that's possible with these infections if it is actually extensive enough. Right, in these cases, they actually say that only oral antiviral therapy is indicated. Again, I still like if there's any blisters on the conjunctiva or any form of involvement of the ocular surface, that I will probably still do a topical antiviral. And then, like they say here, the topical antibiotic is actually just for secondary cover to make sure that you don't have an opportunistic infection. Okay, so here the oral antiviral is absolutely essential to avoid this neuralgia that happens with herpes zoster. Okay, so the full recovery takes up to 2 to 3 weeks. And you can give them a cream. You know, sometimes there are creams that they can apply to the blisters on the outside of the face as well. Okay, so this one I had to practice again because pronouncing this is kind of sometimes a bit of a challenge. Onchocerciasis. Ha, I got it. Onchocerciasis. So I don't know about you guys in Angola, but this is actually something that, again, I have never seen. This is called river blindness. So it's seen in rural and very rural third world, fourth world countries where people are exposed to flies and a lack of physical hygiene. And what happens here is the fly actually carries eggs and larvae, which the larvae actually breed into the patient's body. So very often with onco is these patients have got these lumps on their body, their arms and their legs, where the fly actually lays their eggs. The larvae actually then kind of breeds out into the skin, and then they migrate throughout the body. And the ocular involvement is mostly created by an inflammatory response to these worm larvae, more so than it being the larvae itself causing the damage. So let me explain that. So the larvae will actually migrate throughout the body, and they will go and die in certain tissues in certain places. In this case specifically, they migrate to the corneal stroma, and they die there. And the actual degradation process of the worm larvae is the thing that creates the scarring and the damage to the ocular structures. Okay, so and it's corneal scarring that's created, not so much. I always thought it was something in the sense that, you know, these worms were kind of causing penetrating wounds or causing you know, damage by eating structures, and that's not the case at all. It's an inflammatory response to the actual tissues that the larvae leave when they actually die off. Okay. Here you also have an itchy eye, and you have this really blurry. So what's the management of onco? Onco is managed by antiparasitic drugs, and it's actually quite an easy thing to manage. Normally you give them one dose and the parasite dies off and you have no problem, you know, and it's a preventative condition as well. These people can get educated, and with better hygiene and water to clean their faces and getting rid of the fly issue, then a condition like this should not happen anymore. Okay, now I put that in brackets. So the most commonly used antiparasitic is ivermectin. Ivermectin has received a lot of attention over the last 2 years, but this was actually what ivermectin has been used for in ocular management for conditions like this, where worm infestations are needed to be treated. And then the oral tetracyclines. Now, tetracycline has got an incredible capacity to prevent inflammation and prevent collagenase and collagen degeneration, okay? So it stops the cornea from going cloudy. It stops that whole scarring inflammatory process. So even though tetracyclines are an antibiotic, it has a big role here to play in the inflammatory response more so than treating the actual parasite itself, okay? And then obviously surgical removal of the lumps. So what they normally do is these patients, whatever lumps they have, they actually remove that larvae and that, parasite that's lying in those lumps on the skin to avoid it from actually traveling through the system, okay? And then, like I said, it's easy to manage. Every 6 months, patients should be treated prophylactically every 6 months. And then this really should not need to occur and create these devastating effects. Okay. So going into peripheral corneal disorders, here we're talking about non-infectious, or shall we say sterile corneal ulcers. Okay, sterile ulcers or peripheral corneal disorders are associated with connective tissue disorders, things like rheumatoid arthritis, where you have arcus. Now, arcus is the early stage of a peripheral thinning or peripheral degeneration of the cornea, okay? Then systemic lupus and things like that, okay? Things that fall into this class is marginal keratitis, Murine ulcers, pellucid marginal degeneration, peripheral corneal melts, and things like that. Okay, so this is quite a wide area of discussion, but the main thing here is that it's non-infective. The cornea just starts to either cloud, around the periphery, it starts to scar, or it starts to thin down. And this is just a slow process over time. And then when it thins down to such an extent that it could get to a perforation, then only the eye really becomes very red and painful. It's not something that happens right at the beginning, okay? So you can normally follow this on quite over a period of time. And it's something that's really, we tend to, especially with arcus, we tend to go, oh, okay, that's there, it's fine, and we don't always look at it as closely as we should. And measuring corneal thicknesses there should be quite important to make sure that this doesn't progress into a peripheral disorder or a marginal thinning, and then obviously an ulcer at a later stage. When the patient then presents with an ulcer or a sterile ulcer, obviously they'll have pain and they'll have the redness that goes with that. But the classic thing here is it's non-infective, okay? There's no bacterial component, there's no organism component, right? And that makes the treatment quite a bit different and safer, because you'll have to put a steroid onto this eye. One of the other signs you'll have is you might see some neovascularization around the area of affected corneal tissue, with the eye trying to put oxygen and trying to alleviate that area by putting blood into that system. Okay, so what do we do in these cases? Again, the topical antibiotic drops or ointments are used. Always when you have an epithelial defect, you want to just cover it prophylactically to avoid secondary infection, okay? Now, the difference here, and that's how you'll tell the difference, viral conjunctivitis or viral keratitis doesn't cause this corneal defects that look similar to a bacterial ulcer. So the ulcers look very similar to bacterial, yet there's no discharge, and there's no anterior surface chamber response as much as there is with the bacterial, okay? But you're going to have a stain. You're going to have the epithelial break or epithelial defect that looks very similar to a bacterial ulcer, okay? So the antibiotic drop to cover the break, and then you want to give a steroid. The steroid is there for the inflammation, because it's the inflammation that's creating this or that's escalating this problem. And very often the inflammation creates more corneal thinning and actually aggravates the process altogether. Then you want to do the artificial tears to keep the eye lubricated. Again, here the oral tetracyclines have been indicated. And remember what I said, it's the anti-inflammatory property, as well as its collagenase capacity to help collagen in the corneal structures to actually not fall apart. That's maybe the easiest way to explain it. So it just strengthens the collagen fibers in the cornea, and it stops the inflammation as well. Okay, so that's a really good option to use in these cases. And then you want to refer for systemic management, because remember at the start I said this is a connective tissue issue. So there has to be some form of systemic condition that's creating this inflammation. The inflammation is coming from the inside. So you want to send that patient for blood work, for inflammatory factor blood work, to make sure that you manage the actual systemic problem. Right. Here again, your follow-ups are daily. Any form of epithelial break, I like to see daily, and then a week. And remember to taper your steroids. If you're going to put a patient on a topical corticosteroid, you want to make sure that you taper it down effectively. Then SBK. So SBK is, again, a very broad term of just saying that the corneal, there's breaks in the corneal epithelium, which is creating staining. So superficial punctate keratitis is the term for every single stain that you'll see on the cornea, but it can be associated with many different things. In this specific context, though, SBK is reserved as its own condition, and as its own condition, it's generally because of dryness. Okay, so obviously you're going to have SBK with filamentary keratitis, and you're going to have SBK probably with, you know, many of the other ones we've just discussed. But SBK by itself, without an infective component, without an ulcer, without any other association, is commonly due to some form of dryness. And probably one of the most common types of corneal staining I see is this inferior corneal staining. So you'll see in this picture, the stain is lying into the half to the lower third of the cornea. And that's very common in like an exposure keratitis situation. So either the patient doesn't blink fully when they're awake, or when they sleep, the eye doesn't close all of the way, right? And again, in this picture, you can see that there's quite a low tear meniscus height, quite a low tear lake at the bottom of at the lower lid. So it's very possible that this patient has got a low aqueous production with some exposure that's creating this dry area on the front of the cornea and creating the SBK. Remember, I said dry eye is a very big section. I know you guys have had some talks about dry eye. This falls in that dry eye category. There's so many options in terms of what can be going on here, but you want to look at where's your staining. Where's it lying? Is it at the top? Is it at your 3 and 9 o'clock positions? Is it at the inferior portion? You know, and that will tell you exactly what the mechanic is around why you have that SBK, right? The patient's symptoms is the teariness, the foreign body sensation, foreign body very often so because they can actually feel that kind of grittiness. And then the extent of the SBK can vary greatly. Right, the management here is obviously the lubricating drops, especially because it's a dryness component. And I think I want to just say this at this point. Don't just go with any form of lubricant, okay? Go and do your research. Come and listen to one of my dry eye talks about what lubricant you use for what, because there are so many on the market, but you want to be specific. We cannot go through the, oh, this is the sample I have, just use this, you know, route. You have to be specific. Find out and figure out exactly where the dryness lies. Is it an evaporative? Is it a mucin? Is it a mabum? Is it an aqueous? And treat it with the right type of drop, because your patients are going to be very happy for it, because it's going to work quicker and it's going to be more effective in the long term. Okay, so don't just treat the symptoms here, and don't just treat the signs either. Find the cause and fix the cause, right? If it's more severe, you can put a topical antibiotic onto that to just cover the break in epithelium. Very often it's not necessary because it's just a kind of a separation in the hemidesmosomes of the epithelium. So it's not like it's a abrasion where the epithelium is being torn off. It's just that the epithelial bonds are not strong. It's kind of separated a little bit because of the dryness, and the fluorescein goes in between. So topical antibiotic is not always necessary unless you might think there's a contact lens involvement, in which case you probably want to do that. Again, cycloplegics if necessary, very, very rare that you need that for SPK, and then treat the underlying condition. The dryness, do a proper dryness evaluation, figure out where it's coming from, and manage that effectively. Right, and then 2 days to see resolution, and then further management, obviously, from there. But with SPK, the main thing is finding out why. Where is it coming from? What is the mechanic around it? And treating that mechanic, and not just fixing the SPK, because the patient will just be back 2 or 3 or 4 weeks later with the same thing, and you'll just be going around the same bush. Okay, so you really want to try and fix the problem. All right, and then the last one for the corneal section is SLK. So superior limbic keratitis. SLK is associated with thyroid disease. So this is very common with women, specifically women with thyroid disease. And what happens is the symptom is you get the sectoral redness, usually towards the superior portion of the sclera, from the limbus of the cornea up to the top. Okay, and it makes this little wedge towards the top. You could even have a little bit of pannus on the top area of the cornea. And there's this big red area, usually where the conjunctiva and the cornea and the limb will come together. Okay. Patient complains of this foreign body sensation, teary eyes, and the burn. Now, something that I've always seen in working with other eye care professionals is that, you know, we tend to kind of miss the top area. You kind of look at the bottom, you kind of invert your top lid, but it's very good to actually have the patient look down and pull that top lid up very high, so you can see exactly what's happening on that top section of the sclera. Okay. You might have some SPK again on the top area of the superior cornea and the limbus, and then the conjunctiva around as well. In these cases, you want to also put lissamine. So lissamine will also give you a good idea of what's going on that conjunctival tissue, because you might actually have some lissamine staining there as well. Okay. And again, the pathological function here with thyroid disease as well is that there's also a big dryness component and a friction component that is creating this inflammation at this top section. If this patient presents like this and they have not been tested for thyroid problems, please refer them to have their thyroid checked. Okay. Here again, we're sitting with lubricating drops. Again, please choose the right lubricating drops. You're going to want to use an anti-inflammatory, and a mild one is fine. So something with a lower dose of Predmild or Alrex will be fine to eliminate the inflammation. And then, yeah, the topical immunosuppressive agent, something like cyclosporin, works really well, because this is because of an autoimmune reaction. Okay, and the autoimmune reaction is what's creating this inflammation. So a cyclosporin works really well. But generally, if you get the thyroid disease under control and you have the patient dry eye managed effectively, then this resolves actually quite quickly and quite easily. Again, the follow-up is 2 weeks. Bandage lenses can be used if it's extensive, but I've found it's seldom necessary to go that far. Okay, so that is the section on cornea. I don't know, Wattie, I don't know if you want to do questions now, or if we finish the trauma section before we do any questions, but I'm going to switch slides in the meantime.
I think that you can carry on. You can carry on presentation, and then we will have some questions.
Perfect. All right, let me just find my other one. Get over to the next presentation here. There we go. Right. Okay, so let's get into ocular surface trauma. And I'm going to say this, you guys are going to think I'm funny, but this is probably the section I enjoy the most. This is the work I love the most, and probably the stuff I see and do the most of. It can be quite dramatic and it can be quite sad because some traumatic events are unsavable. But this is really something I enjoy, and I've done a lot of work in my practice on this because we're in an area that's quite rural and quite far removed. So yeah, we've seen some crazy things. I just pulled a study just to kind of give you guys a perspective, and where I want to go with this discussion is that in the Baltimore Eye survey that they did, you know, I think this was done in many years ago, 1993 or something like that. There was a study done to say, okay, which was what was the prevalence of men and women that tended to get, you know, traumatic injuries, you know, and obviously men were on the higher spectrum, and they said it obviously is because of vacation, because of work. So I would say 98% of ocular traumatic events occur at work, at a job, a place of work, and something that was probably quite preventable, right? I had some questions there. I decided to leave them out because, you know, on Facebook Live, it's not that easy to do. So it doesn't matter right now. Okay, so let's get into the traumatic events that you will see in practice. So obviously the corneal abrasion is the first one. And as we've spoken through these other sections, corneal abrasion can also occur from your hand. You could have created one by debriding a filament from a filamentary keratitis, you know, for instance. So this is what will happen and how you will manage it. But you might actually get a corneal abrasion that comes in because of a traumatic event. And it's those ones that you've got to be careful for, because what is the reason and what was causing the corneal abrasion is the important question. All right, so these patients will come in severe pain. They are absolutely in excruciating pain. They're light sensitive, they're photophobic, they got teary eyes, they've got this foreign body sensation, and normally come in like clutching their eye. And because of something that happened. So either something scratched the eye, they had a finger in the eye, and when you look at them, you'll have this break in corneal epithelium. This picture, this was actually quite an extensive one. This picture was from a farmer. He was quite old at the stage when I saw him, and he had an event where something went in his eye and it was painful and it got worse, and he self-medicated with a topical anesthetic, right? So he just decided he's going to, because he's a farmer, he's got it for his cattle, he was just putting his own topical anesthetic in. And topical anesthetic actually makes the corneal epithelium very soft. It actually degenerates corneal epithelium because it's toxic. So instead of the abrasion getting better, it continued to get worse. And now he didn't feel it, obviously. So by the time I saw him, this was the extent of his corneal abrasion. It was covering probably about 80% of his cornea. And we were very close to a perforation, and it had already gone into his stroma. So this eye was completely scarred and we lost the vision of this eye. But you will see some crazy things, you know, in this world. So what is the science here? You're actually expecting this epithelial defect, this break in epithelium. Now, like I said, right in the beginning, we spoke of bacterial ulcers, is that with a corneal abrasion, the difference between a corneal abrasion and a bacterial ulcer is the edges. Okay, so you'll have a distinct edge of an abrasion where the skin, where the fluorescein stops, where with bacterial, you kind of have this little fluffy edges, almost like the fluorescein kind of disperses into the rest of the corneal tissue. And with a bacterial, you'll have that hazy edge. Remember, I talked about that hazy edge around the defect. Here, there's no hazy edge around the defect. Okay. Unless they've been walking around with this for a few days or weeks, then it'll start kind of ulcerating and causing haziness as well. But acute corneal abrasion has got this defined edges with no haze around the outside. You'll have this red eye, and you might even have anterior chamber reaction if the abrasion is severe enough. Okay, so what do? Firstly, I like to get rid of whatever epithelium is there that doesn't look healthy or that's loose. Epithelium needs to re-heal, and if you leave bad, old, degenerative epithelium behind, you take the risk of actually having a recurring erosion later on because the epithelium is not healing properly. So you want to rather take that abrasion and make it bigger, you know, and get rid of all the dead tissue around it now, rather than having a recurrence later on. In this picture, that was a patient who had a laceration from a child poking his finger in our eye, and it was actually quite small. So again, if I can get my pointer here, my pen here, so I'm going to just draw a line. So the laceration was kind of, let's say, about that size, okay? And what had happened is the epithelium was kind of flapping a little bit, you know, in that cut. But it was closed, technically speaking, and the epithelium was just flapping. And I had to make that call and say, okay, am I going to just leave it like that? Or am I going to just clean it up nicely and make sure it heals properly? And we went this route, and I'm very happy we did, because literally 24 hours later, the epithelium had reclosed up, her pain was gone, her eye was perfect, you know. Whereas if I hadn't done that, the chances were that there was still some things stuck underneath, and then we worry about having these fungal issues, you know, 2 or 3 weeks later. All right, obviously put an antibiotic ointment on there if you're going to debride, because you're creating a bigger defect on the corneal surface. If it's a contact lens wearer, you want to put a fluoroquinolone, very strong antibiotic. You can put a cycloplegic if it's necessary. Again, you can use your oral NSAIDs for pain. Do not put a topical, use an oral. Be careful for stomach problems and gastro issues. And then if the abrasion is larger than 50% of the corneal surface, you can then put a bandage contact lens. Now, just as a trick with a bandage contact lens, don't forget that when you have them back and you want to remove that contact lens, make sure it is loose. So what I always do is I have them wear the bandage lens for at least 24 hours, okay, when I have them back for their recheck. Then if I decide to remove the bandage lens, I actually soak that eye with a lubricant. So I put like 3 or 4 or 5 drops of ocular lubricant into that eye, make sure the lens is loose before I try and remove it. Because if the lens has attached itself to the healing epithelium and you don't loosen it up, you actually just create a new abrasion when you remove that bandage lens. Okay. Then patching. Okay, so I've had a couple of controversial discussions about patching. Patching has been, or used to be, the go-to thing for traumatic events. And over the last few years, it's really become less and less popular. I don't patch at all, okay? Because patching creates this warm, dark environment that is so perfect for bacterial overgrowth. And it could actually make the problem worse. So I normally would, if I then want to patch, put a bandage contact lens, which is sometimes referred to as a soft patch, you know, so put a bandage lens in the eye on the cornea instead of having a full hard patch cover on the outside and closing the eye up for a few days. Okay, so, and many people, and it's getting to the stage where outside patching, covering of the eye is no longer done. Okay, this patient you'll follow up obviously in 24 hours. Remove the bandage lens and then continue treatment, making sure that the size of the abrasion continues to get smaller. And it normally takes about 48 hours to resolve completely. Even a full 100% corneal abrasion should heal up within 48 hours. The eyes are amazing. It really does go quickly, and it heals up very quickly. And then always remember to monitor on your 14-day mark to make sure that there's no secondary fungal infection after, you know, an incident like this. Right, then we go to foreign bodies. So foreign bodies, again, is quite common. And foreign bodies can present in many different ways. You can get corneal foreign bodies, you can get conjunctival foreign bodies, you can get lid foreign bodies, you can get intraocular foreign bodies. So it all depends on what happened and what it is the person was working with. The most common foreign body is metal-based, so people that were grinding or welding, and those pieces of warm metal come off and they get stuck and embedded into the eye. And then the less common is projectile foreign bodies, which are always tend to be more severe and more penetrating. So the moment something moves at a high velocity, you take the risk of it penetrating and really causing quite a lot of damage on its way through. So these patients, also the red eye, the foreign body, the teary eye, and you'll see this particle stuck somewhere, either on the cornea or on the conjunctiva, and then yeah, depending on where it is, the pain might vary depending on where it is. Okay, So intraocular foreign bodies is important to rule out. So you want to check for iris tears, irregular pupils, maybe a lens or a capsule perforation, high femurs, and then low IOPs. You want to stay and make sure that there's no leak and there's no Sadal sign, that there's nothing that's actually gone through, you know, the corneal or the ocular tissue completely. Okay, so be careful for that. Another trick that's important with foreign bodies is try not to anesthetize straight away. Okay, have the patient in the chair first, because many times a foreign body is embedded underneath the superior eyelid, the top tarsal conjunctiva. And just by removing that, you can then have the patient respond saying, oh yeah, this feels a lot better. Whereas if you anesthetize them, you don't know if you actually removed everything that was bothering them. So even if you see the foreign body on the cornea, you're like, oh, there it is, it's black, I can see it. Still go and do an evaluation before you anesthetize. So you can just make sure that you remove anything that's in the lids before you actually go ahead and remove the embedded foreign bodies. So like this picture here is actually a nice example. So this picture, the patient had this little thing got stuck under the top lid, you know, and just by removing that with a cotton bud, they immediately felt better, and they could say to me, yeah, their eyes is feeling 100% better, you know, and I didn't have to go and worry too much about putting any anesthetic into that eye. But usually what you'll do is you'll put a topical anesthetic in, you'll remove the foreign body, and very important to remove whatever remaining rust or particles are there. Use an alga brush for that, it works really well. And because the rust can create ulceration as well. Put a topical antibiotic just to prevent infection. But usually I must say with metal foreign bodies, infection is not common because the foreign body itself is sterile, because it was hot, you know, so it really doesn't contain much bacteria. Plant foreign bodies like this one here is like a little grain of leaf or dust. Those though do have organisms. So you want to, if they've created any form of corneal laceration, you want to put some antibiotics onto that eye. And then you can give them some oral analgesics, oral pain relief, you know, just to help with the pain. Now, something here which is quite interesting is that you might find that, you know, some patients actually have a weird reaction. So I had it once or twice where I put the anesthetic in the eye, remove the actual foreign body, and the moment the patient then actually stands up from the chair, they actually faint. They lose consciousness and they faint. So that's happened to me twice. I must say the first time it happens, you have a very big fright. The second time, you know what's coming. So what happens in these cases is that the combination of stress and anxiety with the anesthetic actually drops their blood pressure. And the moment they then stand up, you know, their blood pressure drops too low and they actually just faint. Okay, so keep that in mind. Be careful. If it's a very big person, very big man and little me, and you can't pick them up off the floor. So you really don't want to have situations like that. So have the person sit just for a little bit, or have a couch where they can transfer to from your chair, where they can just sit and recover to make sure that their blood pressure is stable before you have them walk out. Okay, so this one again, you'll see in 24 hours, making sure that you've removed everything. And then obviously, you know, making sure that it is improving. So it should actually have been completely resolved within 24 hours, unless you weren't able to remove everything, in which case you want to remove the rest and then still have the antibiotic cover until it is completely resolved. Then we go to superficial lacerations. So superficial corneal lacerations are things like, you know, sticks in the eye or finger cuts. I had one lady that had made a laceration like this on her own eye with her mascara brush. So she was putting mascara on her eye, and her toddler came in and like bumped her, and she pushed the tip of the mascara brush, and it's like a metal tip, into her eye, which created this long laceration, you know, very similar to this one, but a little bit longer. But the main thing with superficial lacerations is that they are not deep. They are epithelial deep. They don't go past Bowman's, very seldom into the stromal section. That is more deep lacerations, and it's linear. So you have this linear cut either downwards or sideways. And it could include and go as far as having, including the conjunctiva and the eyelids as well, depending on what actually caused this laceration. So I had once a patient with a brush cutter, you know, those things that you cut the grass with, and they were walking past that, and the brush cutter picked up a rock, and the rock hit him in the eye. So when he came to see me, he had these linear, it almost looked like fish gills, you know, it had these kind of many little cuts, you know, running like linearly across the eye. And there was particles of gravel and sand in those linear cuts. And there was one that was very deep. I actually had to refer him out. It wasn't penetrating, but the rock particles were sitting so deep into the corneal tissue that I couldn't remove it. And he had to literally go and have it surgically removed. Okay, so these things can happen for various reasons and various times. But a superficial laceration is not penetrating, there's no leak, and it's just the epithelium that's kind of flapping a little bit. Right, so again here you want to debride whatever loose epithelium you have lying around. So with this one, I wanted to show you guys, because under white light it's very difficult to see it, but on fluorescein you can actually see it. So I'm going to draw it in for you. So on the right fluorescein picture, you can see there where I'm drawing now, that is actually the break in epithelium. Okay, so that is the piece where the conjunctiva has actually come off. Okay, now I'm going to draw, maybe I should just take a different color. Let me just take a different color. This is the actual epithelium. No, that's a bad color. You can't actually see the blue. Wait. There we go. Now you can actually see this piece here is the actual portion of epithelium that is loose. Okay, so this was a person, it was actually my mother-in-law. She got poked in the eye with a tree branch, and it had cut the superficial conjunctival epithelium, and it actually made this little flap of conjunctival tissue where it had cut loose, and it was actually bunching up at the bottom. So this little piece of epithelium was lying here at the bottom and kind of flapping, and there was this epithelial defect or break in epithelium on the conjunctival area. Now on the left picture, it's very difficult to see it, right? So here, I'm going to draw it in blue again. Here's the epithelium lying all bunched up at the bottom. And then the defect runs from here all the way up like that. So when you see this eye, you're like, okay, it's a bit red, you know, it actually looks quite fine. And then you put it under fluorescein and you go, ooh, okay, it's maybe not fine. But it has this bunch of epithelial tissue that's now flapping at the bottom, okay? So what I do then is you put anesthetic and you actually remove, you actually cut away. So I've got a small surgical scissors. You actually take away that little piece of epithelium so that it can actually grow back effectively, okay? Again, topical antibiotic. When it's metal that's creating these traumatic events, you want to consider tetanus injections to help with or to prevent secondary tetanus infections. And with gaping wounds, suturing might be important or might be necessary. Something that's quite commonly used in ophthalmology practice is wound glue. So they take like a super glue type of base, and they actually take these wounds and they glue it shut instead of using sutures, because there's less distortion, especially on corneal tissue with glue, because sutures tend to create a lot of corneal aberration afterwards, you know, so that's actually quite amazing. All right, so the one contraindication with tetanus is you cannot do tetanus injections when someone is having an acute illness, because it can create a very bad secondary infection. So no vaccines as such while a patient is actively sick. Okay, so this one you'll follow up as well daily until you have complete resolution of that epithelial tissue. Oh, I forgot. I even have little arrows. You see now, I drew it in, but there's the little arrows. So you guys can see where that is. Okay, so radiation keratitis, more traditionally known as arc eyes, is kind of sunburn or UV burn of the ocular surface. Okay, so these patients are incredibly complaining of this severe, you know, kind of scratching, painful eye. but it's quite classic where it happens. This is the 24-hour condition. So a patient would have been welding, and it's normally associated with either welding or snow skiing with this reflective glare that they get from the snow. And literally like 12 hours after they've been doing that, they'll have this incident. Unfortunately, most of the time this happens during the night because they were doing this activity in the morning. And by the time they get to bedtime, this is what the eye looks like. And they have got the severe pain during the night. And by the time they get to you at 8 o'clock or 9 o'clock the next morning, the eye is almost healed up again, you know? So it really is a 24-hour condition, but in that 24 hours, it can be incredibly debilitating. These patients often have a lot of teariness. So in reaction to the foreign body, in reaction to the discomfort, they have this very bad teariness. And science-wise, you're going to have this interpalpebral SBKs. Remember, I said where the SBK is quite important. So it's going to be on the open portion of the eye, not just the cornea, but sometimes also the conjunctiva. So it'll give you this little wedge stain across the ocular surface. You very often have eyelid edema as well. So think about it like sunburn. I mean, if you're going to be sunburned in your face, your lips are swollen and, you know, so this is very similar to the effect. And you even might have them having kind of a flushed look in their face, you know, like a burnt look in their face, and the swollen and maybe a kind of burnt lips as well. So it really has this sunburny type of look to it. And then you also have the conjunctival hyperemia. Again, interestingly enough, also that interpalpebral section. So it's really kind of contained within the open area of the eye. Superior and inferior is normal, and you have this kind of 3 and 9 o'clock wedge of both SBK and hyperemia. So yes, what do we do here? There's really not much. Lubrication just kind of keeps the eye comfortable, and it resolves very quickly. Now, something that happens with these patients, they very often also get their hands on a topical anesthetic, and they use that to relieve the pain. It's the worst thing to do because the epithelium takes longer to heal and it can create big issues later on. So please educate your patients on not to do that. Then oral NSAIDs for pain. Again, no topicals, orals are better. Antibiotic, if you feel that the epithelium needs it. This is very similar to normal SBK in the sense that it's not so much epithelial defect as it is a dryness or a cracking between the hemidesmosome bonds on the epithelial surface. So antibiotic is very often not necessary. And then again, the cycloplegic if it feels that the pain is bad. But the cycloplegic is not going to fix the corneal discomfort. You know, it's not going to numb that corneal sensitivity. You know, so this is more if there is then also an anterior chamber reaction, which really doesn't happen. I don't think I've ever seen a radiation keratitis with an anterior surface reaction. Okay. You want to follow them up in 24 hours. They will really be like almost 100% 24 hours later, if not 42 hours. And this is really an easy one. It'll just resolve and keep them on their artificial tears for the duration of resolution. Okay, traumatic uveitis. This one is quite nice in the sense of the fact that you normally get a very extensive uveitis reaction. You can actually see it quite nicely. This picture was actually quite clear, and it's sometimes difficult to see the cells and flare that well. But in traumatics, it's very often quite visible. This happens after some form of event. Most of my traumatic uveitis I've seen has been because of some blunt trauma, mostly either a car accident or a physical abuse, you know, someone punching someone else in the eye, and then they come in with this traumatic case. So you'll have the patient have, you know, this black-blue eye, a periorbital edema, maybe a hyphema on the eye itself with the redness and the swelling, and then they'll say the eye is so painful, and they are light sensitive. Okay? And then when you look at it, this is what it will look like. A few things I want you to look for when you are doing your slit lamp evaluation. So obviously the cells and flare is standard for uveitis. You'll have this circumlimbal or ciliary flush, or the hyperemia around the limbal area. you'll possibly have pupillary changes. And that's quite an important one. Your pupil might be sluggish, okay? And I've found that the pupil actually gets mid-dilated. It almost dilates and stops, okay? It does, and sometimes it blows out. So sometimes it goes all the way open, but that's quite a problem because you might actually have a tear in your ciliary body or in your ciliary muscle. But it's the initial trauma creates almost like a paresis of your ciliary muscle, which creates the pupil sluggishness and actually mid-dilated. It kind of gets stuck somewhere there in the middle. Okay, so that's something to look for. That should resolve. Because if it doesn't and it doesn't come back, you have to look for ciliary muscle tear and possible peripheral retinal tears as well, because then there might be an actual tear within that ciliary system. Okay, and then you might have fluctuations in your IOP, and you might have both a low and a high IOP. And this is because of your trabecular meshwork also having a similar reaction to this impact. So a lower IOP creates kind of a blowout of the trabecular meshwork, which creates a lot of drainage and drops the IOP. Or the alternative can happen, it can actually spasm up and close the trabecular meshwork, which will actually rise the IOP. And if the IOP is too high, you have to actually manage the IOP as well. Right, so the management, topical cycloplegics and then topical corticosteroids. Here you want to go full dose corticosteroid. Pred Forte is still the go-to. It still works better. Lodamax or lodoprednol has been quite widely advocated because it's got less risk for IOP issues, but it's not as effective as Pred. So I still, with these cases, still like to go with Pred Forte and just make sure that you get the inflammation down as soon as possible. And if the IOP is a problem, then you just manage that secondary. This picture at the bottom here was a patient that was in a car accident. You see he's got all the contusions around the face, and he presented with both subconjunctival hemorrhage as well as traumatic uveitis at the same time. So this was quite an extensively bad looking eye, in spite of the fact that he actually was seeing not too badly, and he just needed some corticosteroid drops. With them, you'll also follow them up 5 to 7 days. Make sure that you have your pupil resolution. Make sure you start tapering your cycloplegic so that the pupil starts to recover, so you can see that the ciliary muscles are working again. I normally don't keep them on a cycloplegic for, say, longer than 3 days, so that you can actually start bringing the cyclo effect down and start seeing that the pupil is returning back to normal. And then your corticosteroid, be careful for rebound inflammation. You want to keep them on the steroid long enough that it completely resolves the inflammation, and then start tapering it off. So I normally do at least 7 days on a 4 times a day basis. And after that 7 days, if the hyperemia and the uveitis or the cells and flare is not completely resolved, I'll keep them on another 5 days just to make sure you resolve it completely. And then you taper from there, because if you taper too quickly, you can have a rebound inflammation, and the patient just has this rebound uveitis that comes back again. Okay, then we're talking about penetrating laceration. So we had a penetrating corneal ulcer earlier, where the ulcer was so extensive that the iris actually plugged it from the back. Now, this is exactly what happens in a case like this. So in this case, there was a sharp penetrating object that went in from the limbal area through the cornea and actually went straight into the globe, into the posterior chamber. And what happens in this case, because of the change in pressure, the iris gets pulled into the hole very often. And on the one hand, I'm actually always quite impressed by this almost self-fixing capability of the eye, because if that doesn't happen, the eye will leak out very quickly and it will just completely dissipate. You know, by the iris doing this, it actually blocks the hole and it preserves that eye to be fairly functional, albeit quite painful and obviously needing some help. But it really does save that eye in the process by plugging the hole and making the eye not leak out at a very, very high speed. Okay. In these cases, like I said before, you'll probably see the point of entry, you'll see the pupil pull or a tear in the iris, you will probably have a leaking cornea positive Seidel sign, and then the iris prolapse. If the hole is big enough, you'll actually have this iris prolapse. But a few smaller things to look for would be this keyhole pupil and a traumatic cataract, and then obviously you'll have this anterior chamber reaction and very often a hyphema as well. Right. Now, penetrating injuries are also emergency situations, because that eye is actively leaking and that eye needs to get surgery to avoid it from completely leaking out. So all you want to do is you want to stabilize the eye, apply a shield so that there's no further trauma to that eye, and you want to refer it for surgical management, okay? I always add a topical drop onto it because you want to make sure that the patient has got antibiotic cover as soon as possible before they go off to surgery. Now, this picture, and I always love including this picture, because this person actually came in for a routine exam. This patient came into my office, they were there for a routine exam. And then on their assessment, I had a look at this eye and I kind of went, okay, but did you have a thing? And he goes, yeah, many years ago, something hit his eye, was painful for a few days and then it went away. And I said to him, I mean, you didn't have any operation? No, he had no operation. So the amazing thing about this is that you guys can see that there's a laceration there with some corneal scarring on the side, and you can actually see the linear cut on the cornea. So something went in there. And then when I looked closely, and I should have given you guys the bigger picture, but you can actually see in the bottom of the anterior chamber, like a brown thing. I'm just going to line it out for you here at the bottom. Okay. And it turned out after, and I did a gonio just to have a look, and there was actually a piece of rock lying at the bottom of his anterior chamber. I mean, can you believe it? So he obviously had this projectile that actually penetrated through his eye. I mean, the iris didn't even prolapse in this scenario. The pupil is a little bit pulled, but very slightly. And this piece of rock was still lying in his anterior chamber. Now, the question is, do we need to do something about that? This eye is quiet. There's no redness. There's no irritation. There's no inflammation. He's got no glaucoma. And that rock that's lying there is not causing any trouble, you know? So in this case, we decided that we're really not going to do anything about it because the risk of going in and removing that is higher than the issue that it's causing at this stage. So that was quite interesting that that can occur and a person doesn't even actually really know about it, okay? All right, then we go to chemical burns. Chemical burns normally happen in also in work environments, factory environments, people that work with battery acid that actually kind of explode, and someone that might spill something that can create a burn like this. These can be very, very severe. So chemical burns can go from mild epithelial defects, you know, corneal abrasion burns, to complete limbal degradation and stem cell death, which is really, really bad, you know. So acid burns are always safer in the sense that acid burns are superficial, whereas alkaline burns are very, very devastating. It burns through and it kind of melts the whole corneal structures, the trabecular meshwork, it just melts right through that eye. So it's always very, very scary to see these type of incidents. What you will see in office, a person will come in and they'll complain of this photophobia, the teariness, the redness, and very often a blurriness, because the burn will create a defect on the cornea and very often in the actual visual axis because the person was busy with something when this incident occurred. You'll see the epithelial defect. You might have a conjunctival defect as well. And in these cases, you very, very often have this chemosis. The conjunctiva swells insanely, and there's a lot of hyperemia. Uveitis can happen, but it's not that common because uveitis takes some time to progress. So because it's so acute, the uveitis will present a little bit later, not immediately after the acute incident. Then the limbal ischemia is very important to look for, because if the burn is on that limbal stem cell area, you will lose the function of that stem cells. And that's very bad news for the cornea. It'll create corneal scarring, corneal clouding, and it's really a problem. Okay. And then obviously corneal edema and opacification. So the big thing with chemical burns is managing the inflammation, managing the edema, and the reaction that the eye has to this inflammatory response. Okay. Right. So immediate acute reaction is rinsing. So you want to rinse as well as you can. I normally tell my patients, and when I go to my factories and offices, you literally put your head under the tap, open the tap and open your eye and just let it run for at least 10 minutes. Okay. So you don't want to now pour something, lean over, just put your head straight under a tap with running water. It's the most effective way of getting rid of whatever chemical it is that caused the problem. After that, you want to put a big amount of artificial tears, preferably something thicker, an ointment or a gel, oral analgesics for pain. And then this is quite an interesting fact that I found in research, is the fact that oral ascorbic acid, vitamin C, and high doses of vitamin C has reported to have very, very good prognosis results in chemical burn injuries, because the ascorbic acid helps with the tissue revitalization. It helps that the tissue doesn't swell so much. So any person at work should always keep vitamin C somewhere at hand. So you want to take, like, I think it was like 2,000 or 3,000 milligrams of vitamin C straight away to help with the balance in that eye. And what the research says is that the chemical changes the ascorbic acid levels in the anterior chamber of the eye. And that change in ascorbic acid levels is the thing that creates the corneal clouding and the melting, the corneal melting. So if you can stabilize the ascorbic acid levels, you will probably prevent a corneal melt. Right, then you want to put a topical cycloplegic, and then again, the prophylactic antibiotic ointment. So this is acute care. This thing happened right now. This is what we're doing about it. Right. Then what you do after that is you want to manage the inflammation, like I said, and that is the thing that creates the long-term damage. So put on a corticosteroid to get rid of the inflammation. Give oral tetracyclines being anti-inflammatory and helping with collagen bondage and collagen reformation. And then you will probably need an IOP lowering agent with these cases, because the IOP tends to spike, at least for the first few days. Right, so you follow them up in 24 hours, 48 hours, make sure the epithelium is healed up. You need to monitor them very closely for corneal melts. This occurs at about week 2, and it's a combination between the actual injury and the medication. And then you might have late onset IOP raises. So always remember to keep an eye on your IOP, pun intended, keep an eye on your IOP. And then autologous serum is the go-to for autologous serum and amniotic membranes for chemical burns, because if you have this limbal burn where the stem cells are affected, the eye has got no growth factor and no natural way of healing the cornea itself. So you have to give it something to be able to do that. And amniotic membranes have worked very well. And what it does is it gives the stem cell and the growth factors that cornea needs to regenerate and to heal itself. Then we're talking about recurrent corneal erosion. Let's try that again. Recurrent corneal erosions. So recurring erosions is something that occurs after a previous episode. So when I was speaking about corneal abrasions, I said that you want to debride the epithelium that's been damaged to avoid this. Because what happens in corneal regeneration is that when the corneal epithelium comes back together, instead of it joining properly and the hemidesmosome joints coming together nicely, it actually heaps. So it kind of climbs on top of each other, and it creates this little negative stain area or elevated area in epithelia. It dries out, and then when the patient sleeps, they close the eye and it gets stuck to this little heaped area of epithelium. The moment they open the eyes, that shearing force pulls the epithelium off, and back to corneal abrasion we go, you know. And the interesting thing was, what you will find, the patient will phone you early in the morning, pain severe, they need to come and see you. And then by the time they get to your office at 8 or 9 a.m. in the morning, there's very little to be found. You know, there's no abrasion there. And you have to look very carefully sometimes for these heaped areas or areas of negative staining. So areas of negative staining are black spots within the tear film of green. So you'll have your green tear film under fluorescein, and then you'll have these little black spots, or like in this picture, these little elevated epithelial areas. And that shows you that this is what you're dealing with. Okay. That's a nice picture of a negative stain. So what you'll see is the epithelium kind of lies around it, but that portion that's black, it shows you that it's higher out. It kind of heaps out towards you, and the epithelium is kind of bunching up on top of itself. Okay. So in chronic episodes, you want to treat it like a corneal abrasion. Again, what I do is I will debride. I will get rid of that corneal heaping, clean up all of that bad epithelium, make sure that you have a healthy outlined epithelium so that it can grow back more effectively. In these cases, especially if it's a secondary to a previous abrasion, I really suggest that you go with something like autologous serum to try and make sure that it heals up properly the second time around. And the nighttime lubrication is important. They have to remember to put a drop in at night before they go to sleep to avoid the eye to get stuck to that area. Okay. For chronic, more recurring episodes, then you will look at things like anterior stromal puncture or PHK, which is something you'll refer out for, where the surgeon will then actually treat the basal membrane, the stroma of the cornea to help the epithelium bind a little bit better. Okay, and you will treat this like a abrasion, then put an antibiotic, follow them within a week, make sure it resolves, and keep stressing the fact that they need to keep on with their lubrication. Okay, and then last but not least is probably the worst, is globe rupture. So this is one of the worst things that can happen in any traumatic event. And let me tell you guys the story behind this. So this was a small girl. She was about 10 years old, and she presented to my office with this, and the words the mother used was her eye is small and very wet. Okay. And what the story was is she was walking home from school and the boys were playing and they threw a rock at her, and the rock obviously hit her eye. So yes, so when she came and she sat on my chair, this is what I found. And what you see there is the complete internal content of the globe on the outside. So it had cut obviously such a big portion that it was unable to sustain the pressure of the globe, and the globe just popped towards the outside. Okay. This is an emergency in the sense that you want to avoid secondary orbital and cranium infections, where this is a complete open system now, and a bug can now go into that eye and into the orbit and actually create a bunch of issues. Okay. Now, this is the worst one, and if you're unlucky, it looks normal on the front and the rupture is at the back, which makes it a lot less easy to see. Okay, in those cases, you want to look for a very low IOP. You want to look for flat anterior chambers, so your iris and your cornea is almost touching on the front. It's like it's kind of deflated. Okay, you want to look for choroidal hemorrhages and retinal detachments. If you have a traumatic event with a retinal detachment, you send that out straight away for an MRI, because the chances of it having a break somewhere is very, very good. All right, so the take-home message on ocular trauma is prevention is better than cure. Now, I love my gifts because I think they are so cute, but you rather prevent the injury than sitting with an eye that you can never use again, you know, and unfortunately, eyes are not completely transplantable. So if you lose it, it's gone forever. So the thing that we have to stress to our patients, and we have to stress to the areas that are at high risk for this, is that wearing safety equipment is maybe a bit inconvenient now, but it can protect you from losing your eye in the future. And 90% of ocular traumatic events are preventable. So these should not happen as frequently as they do, and it should really be something that can be avoided. All right, and that is my story. So I trust that you guys have enjoyed that. It's a mouthful.
Well, thanks a lot for this wonderful talk. There are so much information that we need time to read again and to think about it. That was a kind of atlas of cornea and traumatic events. Thanks a lot. Thank you indeed for this. We haven't been waiting for nothing. We have waited months, and we have had a terrific talk. Thanks a lot.
As long as it was worth the wait, then I'm happy about that.
It is actually. It is.
Perfect.
I don't know if my friend René Com is online. Don't know, because I would like to give him the honor to start. He is not online at the moment. I will let everyone to have the ability to because I am just activating. Well, you can activate your audio if you would like. I will start because I would like to start with something which is very practical. After a viral infection, adenovirus or herpes simplex, we have most of the time corneal irregularity, irregular astigmatism, and some scars. So some kind of also of points which would impact sight, impact vision. So after the healing and the resolution of the infection, how do you manage people with such problems? This is my first question. The second is about 9 o'clock daylight sign. Most of the time, we have seen that with the RGPs, with gas permeable, and we know that we can manage with either lubrication and so on, but it can repeat again, and most of the time is just the curvatures of the main meridians. One is steeper than the other, and when we fit with spherical lens, and then it's stuck in this axis, in the horizontal axis, and it gives some kind of neovascularization and staining when we put fluorescein. So my way of managing after resolution is to go to bitoric lenses to get this problem sorted out. The third aspect is two main problems which are not oftenly happening. The first one is neurotrophic keratitis. We have seen some of them, and that's really a problem, because there is no pain, and we know that it could have a sight. We can lose sight. The second is limbal stem cells deficiency. Can you give some kind of feedback about these questions? Thank you.
Yeah, okay, so to start with the first one, in terms of the visual component after corneal infection, is that's always a challenge to manage, because you have to draw the line between saying, okay, is this patient a safe candidate for a contact lens, like a scleral lens, for instance? So if you have the severe corneal scarring, ideally, a scleral lens will actually produce quite a good visual outcome. But with a herpes infection, you're sitting with a patient who very often has a systemic condition and could have a recurrence. So is it systemically wise, and it's a difficult call to make. So I would probably fit a patient like that with a corneal RGP, just to help try and eliminate the corneal irregularity and improve the vision if spectacles doesn't do that. but it's very difficult to manage the infective component and the recurrence of the infective component with the optics, that you need to have that patient see better. The same with herpes recurrence. Patients don't have corneal transplants because why? Because the actual host system just creates the same herpes infection into a graft system. So it's really a very difficult one, but it's quite easy in terms to fit those patients with corneal RGPs. I wouldn't go sclerals with them. And then always remember these things has a result on the ocular surface health in general. So these patients will walk away with an ocular surface imbalance, the dryness aspect, the tear imbalance that comes with, and this whole inflammatory system that needs chronic management, So we have to always remember that those things are going to create the dryness, which was going to create this 3 and 9 o'clock staining if you have them on an RGP. So you want to keep going with your lubrication just to manage those staining profiles and the discomfort, In terms of neurotrophic and limbal stem cell death, those are probably two of the worst things that we will ever see because, there's really absolutely very minimal you can do about that. And the normal neurotrophic keratitis patients present after the fact. We don't pick up corneal sensitivity problems before the patient actually has a neurotrophic keratitis, I've thought about this quite a lot and kind of gotten to a stage where I'm thinking maybe this is something that we should test on all of our patients to make sure that we check corneal sensitivity on patients because we'll pick it up more often. Obviously, with herpes infections, you are guaranteed to have some form of neurotrophic issue. I don't know if there's any way of limiting the severity of that, because the patient just doesn't feel it. They disappear out of your office and they come back when the vision goes. And by that stage, the stroma is scarred and the same thing with limbal. The nice thing with limbal though is amniotic membranes have proven highly effective, in the help of stem cell regeneration. So when you're dealing with a non-infectious limbal or stem cell problem, amniotic membranes are really the way to go. So you want to feed that eye with whatever you can to help it regenerate. And that's pretty much the only way that you can do that. Because even transplants don't work because you've lost your limbal function, So amniotics is really great with that. You muted still.
We have two questions from Dr. Sonia Merad. I don't know if she's online.
Yeah.
Dr. Sonia Merad, can you ask Dr. Sonia Merad? But I have actually the questions. Okay. Do you use vitamin A drops for corneal ulcers and chemical burns? What do you think about therapeutic lenses in this case?
So that's a good question. So there's been a lot of research as well on vitamin A, and it's been used quite a lot in the dry eye space, in terms of stabilizing tear film. And it's, I think, if I'm not mistaken, has an effect on the mucin layer. When it comes to ulcers and chemical burns, it's quite an interesting question because I've never actually thought of how that would work for chemical burns. Obviously, for chemical burns, it will if it has an effect on the tear, the mucin production. I'll actually have to look on that. I'm not sure about ulcers and how vitamin A will improve an ulcer. If it's infectious, obviously. If it's an infectious ulcer, then obviously it's not going to make that much of a difference. But I'll actually go in and I'll get back to you guys and answer that question for you because I haven't actually looked at it in this sense. In terms of therapeutic lenses, like I said, we just discussed, and my idea of therapeutic lenses are things like corneal lenses and scleral lenses. I don't know if there's any other therapeutic lenses that you were referring to. The other option, obviously, is medicated bandage contact lenses. which is something we do in severe infective cases. So what you do is you take your soft contact lens, bandage lens, and you soak it in a fluoroquinolone. Instead of putting the fluoroquinolone onto the eye, you actually soak the lens inside of a fluoroquinolone and put that on the eye as a therapeutic option, you know. But I still find that, you know, you still have to have the patient put the drops in. So it's probably similar whether you're soaking a lens in antibiotic or whether you're just putting the antibiotic onto the eye is very similar. So I hope that answers your question.
Thanks a lot. I don't know. I will just try to give her the possibility to have the audio. I don't know if she could. She said thanks. That's wonderful. So I don't know if there are other questions. My friend Dr. René Combs seems to be here but absent. I don't know what's going with him. I would like to carry on with because I am fitting quite a lot of contact lenses, soft, gas permeable and Cilliers, and I have often some kind of either at the beginning or in the main course of some events such as neovascularization and staining and such on. And we use CCNRIU grading scales to grade corneal staining and every part. Do you use the same scale, or do you have other scale better than this one?
No, it's a good question. I think the Efron scale is still the one that is pretty much well known across the world, you know, and that's the one that we tend to go with. I've got a system called AOS, which is a software system, own grading scale built into it, and then also on my topographer they also use it, but it's all based on the Efron scale. And you know what, technology is kind of, I think it's made us a little bit lazy because we don't have to do it ourselves. You know, the system just kind of does it for you, which helps a lot. And especially with AOS now, AOS also had a kind of a what do you call it, a long distance, a telemedicine function where patients can send photos and the photos get graded before they get to me, you know, so that really helps a lot. But I'm quite finicky, like you say, with scleral specifically. I go through every single landing zone and every margin myself. You want to make sure that that is doing what you want it to do. But in terms of scale, we're still quite used to and familiar with using the Efron scale. I don't know if it's necessarily the best one, but it's functional. And maybe there's time for some research for someone else to come and develop a new scale with some of these things, especially where scleral lenses are concerned, because there's been so much development in sclerals. It might be worth having some. It's your turn. You need to make a new scale for us for scleral lenses.
Maybe one day, I don't know. Anyway, we have again Dr. Sonia Merad with some feedback. She said that actually vitamin A works really well in ulcers, with ulcers. But vitamin C works better in chemical burns.
Yeah.
That's
how I had it as well. So I'm not, and I said to her as well via message, I said it's interesting because I didn't know that vitamin A had an effect on ulcers. It's actually quite a great point, and I'm going to go read up on it. But vitamin C is great for burns. Yeah.
Yeah. Actually, Dr. Sonia Merad is an ophthalmologist.
Oh, okay, fantastic.
So she has quite a good experience in with such events. Well, I don't know if you could maybe if there are some other questions. If you could, because it has taken time. Your lecture was wonderful. We wish to have you one day, maybe in Algeria, give us a talk in a conference and so on. And
and that would be amazing. So you guys, you just tell me when, and you know, COVID is starting to become the end now, so we can actually all get around again. So I would love to, and you guys are, I'd love to be there. So
I don't know if you remember. I had a trip to Durban actually. That was in 1996, a long time ago.
Long time ago.
I met there Sonny Crunch. She was at the time the head of the department of optometry.
Optometry, yeah.
And she was quite very involved in IACL, and I had IACL sponsored my trip to South Africa, and I had a wonderful time there.
Oh, it's amazing. I must say it's a great country, but I'd love to see any country, anyone who would have me. I'll be I'm so keen to travel. So I'm hopefully doing a trip to Dubai soon. So I'd love to come and visit you guys as well.
Actually, we hope. I had also while I was managing a school of optometry in 2007. I had an understanding memorandum with the Durban University and with the School of Optometry, but we couldn't carry on because we had some kind of financial means which we couldn't get at that time. But we are thinking actually that it's better for North Africa, for Algeria, Morocco, and Tunisia to have to join African Council of Optometry than being staying in the MENA Middle East Council, which is
makes sense.
Makes sense because we think that some countries in Africa are doing well in optometry, such as Ghana, Sudan. I don't know a lot of. I don't know about Tanzania, Kenya, if they have.
Nigeria is also quite good.
Yeah, exactly. I met when I was doing my postgraduate in England. I met some Nigerians. They have quite good schools. But that's wonderful. Here in Algeria, we don't. The regulation doesn't allow us to treat, even if we can diagnose some pathology, corneal or lens pathology or conjunctival pathology. We are not allowed to treat. That's because in our courses there is a bit of pathology, but not enough pharmacology. That's the whole point.
Yeah, and I think that's been a challenge in most countries. And I mean, South Africa, we only started that in 2015. I mean, I qualified therapeutic 2017, so it's very new, even for South Africa. But and with Dr. Merad on the call, it would be interesting to hear her thoughts on that. But I feel there's so much primary care gap, especially in a country like Africa where patients are falling through the cracks because there's no primary care at primary hospital level. And there's so many more optometrists in those spaces that can actually at least prevent a lot of these preventable blindness issues with basic management, something like a traumatic event or something like a foreign body, and that's kind of where most of my practice has gone into traumatic management, because that has to happen now, and we are 2 hours away from the closest surgeon, the closest ophthalmologist. And although we work very closely together, so many times I'll send photographs and they'll help me with scripts for things that I maybe cannot script, but it's something that has to be managed straight away to actually save that eye, and I think there's a very big space for optometry in Africa to walk into that space, to actually care for the patients better.
Yeah. Anyway, we are allowed to do screening. It's a good thing to do screening, to have also to measure IOP and to look at the fundus. That's wonderful. Thanks a lot. Thank you again.
Thanks for having me.
We enjoyed your. I think that Carlos Salas would like to ask a question. I don't know.
Hey, Carlos. I haven't seen him for ages.
I will give him the possibility to to ask some. I am just asking him to activate his audio. I don't know what is happening. He was trying to get to have audio, and don't know what is happening. Can you write us a sentence about that so we can help? He has actually the ability to speak on the audio. Welcome, Carlos Salas. Hello.
Hey, thank you so much. Yeah, I'm having issues with my internet connection, so I'm sad because of that. I thank so much, Mari, for the presentation. It was such a great honor, and all the information is quite clear and very useful as always. I really recommend all the Marie presentations and courses that she has, because they are very, very rich in information, and a huge salute to all of you from Costa Rica.
Thanks a lot. Thank you, Carlos.
Thank you. Carlos joined me on one of my dry eye courses that we did a few. Yes, Carlos, when was that? It was like just in lockdown time. You know, we did a big, 5-week international course, which was so much fun. So I know him from there. So thanks, Carlos. It was great hearing you.
Before ending this webinar, I would like you to talk about your pedagogic platform, mygovernment.com, and about also your book, which is on Amazon.
So let's start with the book, and thank you, Gwati, for giving me the opportunity. So the book, and I can show you guys, there it is, I have it with me. So, and I want to just show you the inside. So the idea behind the book was to have something on your table or something at hand that is a quick reference guide. So, and we had a struggle in South Africa, which is a problem in Africa, is the fact that the drops that is available in guides is not applicable in our country. So you're sitting with the textbooks that come from the US, and they're talking about drops that are just not available in our country. So I went and we wrote a reference guide for these specific therapeutic conditions, where you have both the Africa as well as the USA drops. And what that has done is it's kind of covered all of the countries across the world with something that will work for that specific condition. So every condition has got its diagnostic page, its symptoms, and then it's got its whole treatment guide, as well as follow-ups and contraindications, which is also great because you want to make sure that what you prescribe, you actually know what it's going to do to that patient and if there's any contraindications. So it's really a very nice handy guide. It is available on Amazon Kindle in electronic format. Unfortunately, hard copies are only available from me. So you guys are going to have me to Algeria. I'll bring a whole box with, and I'll bring some books with, and we can bring some hard copies to Algeria. And then in terms of GuruMed, so yeah, GuruMed was like such a nice kind of thing that I've always wanted to teach, and I've always wanted to share the practical side of what it is that we do, because there's a lot of clinical teaching, but there's very little practical knowledge, and it doesn't translate always that well. If you hear a lecture about some form of theory, putting that into practice is a whole nother ballgame, And I mean, I've been in private practice. I've run my own practice now for about 13 years. And what I wanted to do is I wanted to take the clinical knowledge, but I wanted to make it practically implementable, both in a clinical level, at a staff implementing level, and a business level, because our practices have to function, So GuruMed was basically structured on that concept. And we've now presented a few courses, and these courses available, of which the dry eye masterclass has always done the best, because the dry eye system creates the whole background behind the theory behind it, but how to set up a dry eye clinic, how to train your staff. There's a whole dry eye staff practice team course where you can actually put your team members in the right places and have you help or have them help you with templates and with record cards and with the business model behind how to make a dry eye clinic work, you know, and that's been really successful. And we've been able to generate so many practices with new income and new revenues in times where it's been really rough, you know, in times where COVID has really made it hard for all of us to function, you know. So there's the dry, then the masterclass, the anterior segment one as well, which goes into what we've taught, what I've taught over the last 2 sections, but in great detail in terms of what drugs, why do we use their drops, what those drops do. And then we are just busy about launching a contact lens one, a keratoconus course with Zachary Kans from the UAE. He's presented a contact lens course for us there. And then there's a couple of business modules as well, Google Analytics, Google Marketing, and just marketing in general. I mean, let's be honest, we're so bad at marketing ourselves. You know, we've never been taught to market our practices. So yeah, so it would be great to have you guys join us on the GuruMed platform. We are planning on doing a lot more. There's a dyslexia course landing soon as well. So we really want to try and give a little bit of information for everyone, but it has to be functional. It has to be practical knowledge to be able to use in business.
A last question, which is etymologically, what does it mean, guru? Is it an African term? Well,
so guru is kind of a very good or a specialized person. So when you say you're a guru at something, you like
guru on the guru.
Exactly, you're very good at something, you know. And the med was just like, okay, because the idea was never to stay with eye care, because even though we're eye care professionals, we are medical professionals. So we don't just do eyes, we do people. So it has to be a bit of everything.
Thank you very much. Next, on the 11th of August, we'll host Dr. Patty Cern, which will introduce us on optometric phototherapy syntonic, which is a kind of neuro-optometry way of treating. I think that it will deal with all the TBI and CVI problems. Thank you again, Dr. Cilliers, and that was a great moment we have shared with you. Thanks a lot.
Thank you guys for having me. I appreciate your time.
Bye-bye. Bye-bye.
Bye.